Hello, I am Nino Stocchetti, and I am recording this presentation from Milano, Italy. My topic is how we treat traumatic brain injury in the ICU across Europe. I have no conflict of interest to disclose, and I would like to discuss with you three main points, taking advantage of data that have been recently published. But let me start from the very beginning. So let's clarify a little bit, where do we come from? At the beginning, there was just military surgery for treating severe traumatic brain injury. And that requires surgical skills and knowledge, a lot of bravery, and of course, the results started to improve when asepsis and anesthesia were put into the equation. Very soon, meaning very soon after the end of the Second World War, it became clear, however, even to skilled neurosurgeons, that surgery was not enough. This is a paper from McIver, was a neurosurgeon in Newcastle, and you see it was Lancet 1958, and that very, I think, wise surgeon was proposing that in order to improve the results, it was necessary to combine surgery with something that had to defend the airways of those patients. For instance, avoiding that oral feeding went on the wrong hole, meaning that physiological oxygenation and CO2 could be useful, adding some sedation and looking at infection and nutrition. So that was really the beginning of an intensive care treatment. So the idea of combining surgery with the support of vital function was very soon at the basis of treatment for these patients. When finally, in 1977, from Richmond, Virginia, the idea that the combination, the winning combination, should include early diagnosis and evacuation of intracranial masses, plus control of raised intracranial pressure, and appropriate, the American way is aggressive medical therapy, including artificial ventilation. So that was the combination that was proposed, let's say, at the end of the 70s. What was the goal for using ICU in TBI? At the beginning, it was clear. The goal was to reduce mortality. And when the Richmond criteria have been applied in a reasonable number of patients, this is a paper from the same institution in 1981, you see that the mortality went down to 34%, compared to 50%, more or less, that was the standard in the most advanced centers around the world. In my country, it was even higher, 72%. That was achieved using different strategies, and I don't have the time of describing them, but let me summarize. The strategies were oriented in two directions. First, by targeting possible goals for treatment, and the second, by escalating therapies, meaning using the more effective, more aggressive, and more linked to side effects treatment only to the more severe patients. This is a paper which is 3 years old, in which with friends, we have tried to separate, to dissect a little bit the different lesions that we have to deal with when we talk about traumatic brain injury. Of course, axonal injury is a different issue rather than contusion or surgical masses that have to be removed by surgery. And we tried also to exemplify a different risk for raised intracranial pressure that translates somehow in a different risk for mortality or persistent disability. More recently, this is let's say, a consensus reached and published in 2019 across the two sides of the Atlantic, plus Australian and Chinese colleagues. We tried to put together an algorithm just to try to use some principle. And I would like to focus on this principle. When possible, use the lowest standard of treatment available. And then we start with something, And if this something is not enough, you can use more aggressive treatment up to the most aggressive therapies like barbiturates or surgical decompression. Now, how these principles are applied across Europe. The data that I would like to share with you, in fact, deal with 65 centers across 18 countries in Europe. And please forgive me, in this paper, Europe also includes Israel. And you see the yellow spots are the centers from the different countries who participated to this study. That is Center TBI. It was being funded by the European community, and it's mainly constituted by two studies. The core study with a very wide and rich data set that has enrolled some 4,500 patients, and a registry with a reduced data set for more than 22,000 patients. The first finding of this study is that we are all aging. The median age, 50 years, and the proportion of patients older than 65, 28%. That is to be weighted in perspective. The enrollment of Center TBI has been played from 2014 to 2017. Let's compare with previous series, 1984, 1987, just to begin with. So 30 years, that's the time span here. The median age at that time was 25 years, now is 50. So in 30 years, the median age of our patient has doubled. That was the first finding. But then looking in detail, the Center TBI study has included patients who have been observed in the ER and then sent home, patients who have been admitted to a regular ward, and patients that have been admitted to the ICU. We are dealing and focusing on this stratum of the study, so with more than 2,000 cases. The second striking observation is that by looking at the neurological severity on admission of those patients, you see that 48%, less than half of the patients were severe, 16% moderate, and 36% mild. Patients with a Glasgow from 13 to 15, really mild injured patients. That was surprising. Traditionally, ICU was indicated for patients who were very severe. When I started my job, the unsalvageable patients were brought to the ICU, but at least patients with life-threatening lesions and very severe were the candidates for intensive care treatment. And since I was not sure about this impression, which was recalling by myself, I looked back. And this is a series that I collected when I was working in another institution. And you see that the proportion of patients scored as severe was 77%, the red slice of the pie. Then, with Giuseppe Citerio and Luigi Beretta, friends that work in Milano in another hospital, we put together and we looked at the cases until the year 2000, some 700 or 800 TBI patients, and in our combined series, the severe cases were 72%. So if you look here, the data from Center TBI are really different from the previous findings. And here we are down to 48%. What is a possible interpretation of it? And that is a paper that has been built up by Gilske and Evelyn. You see the first two authors, brilliant young colleagues who work in Rotterdam, and another group of friends cooperating in Center TBI. And we all together looked at the length of stay, the days that the patients spent in the ICU. And it's quite evident here that there is a spike of patients who stay 1 or 2 days, less than 3 days in the ICU. So if we look at this kind of, let's say, splitting of the cases, we had 120 early deaths, patients who died in the first 3 days, And we got 631 patients who stayed up to 72 hours in the ICU, while 1,400 stayed for longer. This subdivision, I think, was useful in order to understand why those patients have been admitted to the ICU. And you see that among the patients who stayed just a couple of days, there were reasons like post-op, after having had a neurological operation, the presence of threatening extracranial injuries, the need for short-term mechanical ventilation, or, in the great majority of cases, the usefulness of a frequent neurological observation. So what we did was probably to move from patients who were felt to be so severe, to be unsalvageable, or really being at risk of dying very quickly, to patients who were at risk but recoverable. So that is probably the main change that we are observing here in this different subdivision of patients. ICU is expensive. Admitting a patient to the ICU means a big investment in terms of care, nursing, doctors, and financial burden. But if you look at the total days spent in the ICU, it becomes evident that 5% of the total ICU days spent for TBI were devoted to the, let's say, the fast track, the patient who stayed for a short time. Looking this way, it doesn't seem so unreasonable to have made this investment. Was this strategy common? This is a plot that tries to describe the proportion between long stay, early mortality, short stay across the centers. And you see that there are differences. These centers behave quite differently from here. But if you look at the confidence interval, it seems like we are all very compressed around the average. And that leads me to the conclusion that it is a general phenomenon, is not really restricted to a few centers. Is this strategy fruitful? Is that useful for the patient? Okay, let's look a bit at the outcome. ICU in general, short stay, long stay, of course, who stay for a little bit of time had very good results and a very low mortality compared to the others. Now let me conclude. In general, the landscape of the ICU policies is changing across Europe. We got a mortality in these patients of 30%, and using a prognostic model, so adjusting for severity, the expected mortality was 47%. We may conclude that the outcome in general, talking about mortality, was much better than expected, even if we have to admit that unfavorable, so the combination of mortality and patients who are left somehow non-independent after injury is still 55%. So in conclusion, what I have tried to discuss with you is that we come from a long track. ICU for TBI has not changed much, but what is changing is probably the use of the ICU resources across Europe. Thank you for your attention.